First of all, I'd like to thank the movers of the motion. It is not just an emotive motion, but something that's very pertinent and indeed something that needs to be dealt with. At the outset, I would like to start to explain precisely what symphysiotomy is, to give some context about its use as a medical procedure and specifically its use in Ireland. Symphysiotomy is a medical procedure that was primarily used before the advent of safe caesarean sections. The procedure was carried out in Ireland from about 1920 until the early 1980s. It was gradually replaced by caesarean section as the preferred method of delivery in childbirth where required. It is quite clear that the procedure continued to be used in Ireland for some time after it had been all but discontinued in other developed countries. In that regard, within Ireland, it continued to be used for a longer period, most notably in Our Lady of Lourdes Hospital in Drogheda. Both myself and Minister Riley are conscious of the distress that symphysiotomy has caused to a number of women and recognise the pain that this issue has caused to those affected by it. The Government is committed to dealing with it sensitively, so that, if at all possible, this issue can be brought to an appropriate and fair conclusion for all women affected by it. Our first priority is to make sure that the health needs of those who have had a symphysiotomy are met quickly and efficiently. With this in mind, we are committed to ensuring that the greatest possible supports and services are made available to women who continue to suffer effects of having undergone this procedure. The women concerned continue to receive attention and care through a number of services which have been put in place, including the provision of medical cards to all who requested them, the nomination of a liaison officer for a patients group comprised of women who underwent a symphysiotomy procedure, the availability of independent clinical advice for former patients, the organisation of individual pathways of care and arrangements of appropriate follow-up for women, including medical assessment, genealogical assessment, orthopaedic assessment, counselling, physiotherapy, reflexology, home help, acupuncture, osteopathy and fast-tracked hospital appointments. The refund of medical expenses related to symphysiotomy in respect of medical private treatments, and establishment of a triple assessment service for patients at Kappa Hospital Dublin in January 2005. The support group facilitated by a counsellor, which was set up in 2004 in Dundalk and Drogheda for women living in the North East region. The nomination of a national lead officer for symphysiotomy. In addition, there are 5 designated regional liaison officers in place across the regions of the HSE. The provision of these necessary support services for women is monitored and overseen by the Health Service Executive, who are committed to being proactive in seeking out and offering help to women who underwent a symphysiotomy and who may wish to avail of the services offered by the HSE. The figure of 1,500 symphysiotomy has been suggested for the periods 1944 to 1992, giving a rate of approximately 6 symphysiotomies per 10,000 births. While there was a large variation, even in the hospital with the highest rates, the maximum rate appears to have been 6 per 1,000 births in 1 year. Thus, it was a rare intervention in comparison with caesarean section, for example, which rose steadily in the same period from 3 per 100 births in the early 1940s to now over 20 per 100 births. This is not in any way to minimise the serious effects and suffering that it has had on women and the women concerned, but it does indicate the procedure was quite rarely carried out in Ireland overall. We need to act on the basis of best evidence that is available in relation to this issue, as in all aspects of our health services. To this end, the Chief Medical Officer of the Department of Health commissioned an independent research report last year into practice of symphysiotomy in Ireland. The aim of the report is to provide an accurate picture of the extent of the use of symphysiotomy in Ireland and an examination of the Irish practice relative to other countries. It is to include an assessment of the circumstances in which the procedure was carried out, what protocols or guidance existed at the time to guide professional practice, and details of when the practice changed and why. Specific terms of reference the researchers are given are: document the rates of symphysiotomy and the maternal mortality in Ireland from 1940 to date by reference to available data, including annual reports and other reports. Assess symphysiotomy rates against maternal mortality rates over the period. Critically, appraise international reviews of symphysiotomy practices and associate rates in a number of comparable countries in the world and in Ireland. review any guidelines and protocols that apply in Ireland on symphysiotomy over the same time period, write a report based on the findings of the above analysis, providing an accurate picture of the extent of the use of symphysiotomy in Ireland and an examination of the Irish experience relative to other countries. The academic research concerned was formally appointed on the 1st of June 2011. The academic researcher concerned was formally appointed on the 1st of June 2011. The researcher experienced unforeseen difficulties in accessing information sources and as a result submitted a report behind schedule in late January 2012. The researcher informed the department that this was due primarily to the challenges with accessing historical data from a time when records on the procedure were not routinely kept. In line with best practice, Minister Riley has initiated a peer review process of the draft report, and he proposes to make the report available for consultation with relevant individuals and bodies this month. Following the consultation process and taking into account the outcome of the peer review, the report will be finalised and published. The Minister will then consider the final report and decide on the next step required to address the situation. Ireland is now one of the safest places to have a baby. We have one of the lowest maternal mortality rates and perinatal mortality rates in the world. Ireland is now a very safe place to have a C-section, and we should be proud of the fact that we are recognised internationally as leaders in the field of obstetrics. Recent legislation requires doctors to maintain and update their competence. These new requirements for doctors to maintain their professional competence are a significant step and a concrete assurance that medical practitioners are appropriately qualified and competent to practice safely. The National Clinical Effectiveness Guidelines published last year provide a framework for national endorsement of clinical guidelines and audit to optimise patient care. These guidelines will contribute to improving health outcomes by reducing variation in practice, improve quality of clinical decisions, influencing health service policy and informing service users and the public about the service they should be receiving. These and many other developments are ensuring that the health system is striving to fulfil the vision of the Commission on Patient Safety and Quality Assurance, knowledgeable patients receiving a safe and effective care from skilled professionals and in appropriate environments with assessed outcomes. The new clinical programme being developed and implemented in the HSE are one of the most important developments in this regard. These are currently led in the HSE by Directors of Clinical Strategy and Programmes, which was established to improve and standardise patient care throughout the Health Service Executive, by bringing together clinical disciplines and enabling them to share innovative solutions to deliver greater benefits to every user of HSE service. The clinical programmes are a multidisciplinary initiative between the HSE and the various faculties and generally include patient representatives. Each programme is led by a clinician. The clinical programmes are a sea change in the way we provide healthcare in Ireland. This new approach utilises key proven drivers of success in improving disease management and is aimed at improving patient care. The Obstetrics and Gynaecology clinical programme is led by Professor Michael Turner. The aim of the Obstetrics and Gynaecology programme is to improve healthcare choices for women. Their initial work aims to implement guidelines, establish local programme implementation groups to facilitate change, develop national models for maternity care, develop a standard approach to capturing and reporting audit and performance metrics, develop solutions and guidelines to reduce a number of multiple pregnancies requiring neonatal intensive care, develop workforce planning and training models and strategy, investigate the number of women attending for antenatal care in early pregnancy. More generally, there has been considerable progress in the options of maternity care available to expectant mothers in Ireland. They now have a number of choices. They can make it in respect of the obstetric care which they choose. Women may opt for a combined care package with their GP and the hospital under the Maternity and Infant Care Scheme, which provides a number of free GPs and maternity hospital visits to all eligible expectant mothers. There are also a number of midwifery-led units nationally which offer the opportunity to expectant mothers to give birth in a uniquely designed birth room cared for by a team of experienced midwives. These units are located close to the hospital should an emergency arise and that would require specialist intervention. While these developments can bring further developments to maternity health services in the future, both Minister Riley and I are committed to addressing the issues that have arisen from the legacy of past practice in relation to symphysiotomy. The Government is also committed to dealing with this whole issue with all the sensitivity that is undoubtedly required. To help do so, however, whatever can be done can help to bring this issue to an appropriate finality, as far as is possible for those affected by it. I have outlined the supports that have been provided to women affected and the progress in finalising the research report. And we hope to bring this matter to a satisfactory conclusion as soon as possible, as I firmly believe that the women who have had this procedure in the past deserve no less.